And now as we move on, a lot of interest generated in TAVR procedures now. Once it's accepted, now it is becoming more and more freely available in many centers. That's why I requested Susheel to take through the basic steps. After we heard the visionary talk, we'll also hear from Susheel the basic steps of TAVR and what are the precautions we need to take. And we have learned a lot from him, as Madam herself told. He helped us in establishing this program in our hospital. Thanks, Susheel. I think over to you, Dr. Susheel.
But I think what Marty said and Dr. Mehta said there at the end is, I'm always fascinated by how innovation progresses. The things that I would think are never feasible. And I think, Marty in the past has shown a slide of his initial conversations with with Alain Cribier when they were doing the first case. And he always makes comments and comments that he got that people called it stupid, crazy, careless, reckless, all those things. And the reality is, a lot of these things you have to be a little bit reckless. You have to have some daring to innovate. And, and I think especially in regions like India where rheumatic and MAC and other things, some of these things are not going to work, and we have to have the courage to do them still and understand that they'll fail because, in the end, that's how we're going to get to the point where we are. And, when you look at that initial slide, I always love that slide of, all the things in comments that he got that, if you don't do that, you're not where we are now. And I think that's one of the things that I would really sort of, Marty Salk is visionary, but it really highlights what, he's done and others in the field have really done to move it forward. So I'm going to give a slightly different talk. And it's hard. I'm going to try and go through this a little bit quicker just to save some time. Try and go through it in about 10, 15 minutes, because it's hard to go through all tips and tricks and all to talk about all the different concepts in a period of, it's really a half-day course. And I think, part of the thing, and we've seen TAVR really sort of go across India, and I think there's a lot of learning, and I think there's a lot of these meetings that are happening there where people are sharing their learning. And the reality is, the goal of TAVR is to unload the heart, right? And when you unload, the heart recovers. And even in a normal EF, unloading the heart improves the mechanics of the heart. So the goals that affect the recovery and what we really need to sort of do is minimize leak, because that increases the load, minimize patient prosthesis mismatch and avoid residual gradients. Avoid conduction disturbance if possible, because then again, the LV mechanics are improved, and don't create other problems. Don't create MR, and other issues. And those are the key things that are going to improve the outcomes and everything else. And these are sort of acute results. Obviously, longer term, there's a bunch of other issues that we need to address, such as access to the coronaries. And we saw that, and we were discussing that with Dr. Grube this morning in the live case. And then fundamentally, valve durability. And valve durability is not a simple, straightforward thing. It's not just recalcification of the valve. It's leaflet thrombosis. It's sort of hemodynamics and longer term. And it's part of that lifetime management strategy discussing all morning. One of the key things about, the biggest tip and trick is about pre-procedural planning. TAVR is a fairly straightforward procedure. It's a simple procedure, and in the right anatomy, and as long as you understand what the limitations are and where the case can go wrong. And to understand where the case can go wrong, besides understanding the patient anatomy, you have to understand the device and its limitations. And you have to have meticulous procedural technique. And it's really, we discussed in that case by Sanjay this morning about, he talked about he had a pacemaker perf, ended up getting a tap a little bit later in the day. And some of these are not avoidable, but sometimes they are avoidable. And sort of, it's not just the TAVR implantation, but it's every aspect of the procedure, from vascular access to pacing to how you manage anesthesia. Someone with a low EF, you can have an anesthetic complication. I think that's important. And in the end, you can do all these things, but yet you do everything right and something bad still happens. And so you have to be willing to accept that. There are certain things that you can't control, such as stroke and everything else. In the US, these are the two main platforms, the SAPIEN 3 and the Evolut Pro Plus, as we saw this morning. Just real quick, I won't go through this, but the data from low risk to me is really transformative. It is what TAVR is right now. Mortalities very low, well under 1%, 0.2%, stroke 1%, pacemaker rates 5 to 6%, bleeding complications 2 to 3%. This is where TAVR needs to be. And it's not just in the low risk patient. The data from high risk, it has much higher complication rates, but it's not that those complication rates in the higher risk patient is representative of our initial experience and learning. These rates are what we should get with all of TAVR. Yes, there are some sick patients where you're going to get bad outcomes, but these are not just outcomes for low risk. This is representative of the learning that has happened along the way. And the high risk trials were done 10 years ago when we had a very different patient experience, different devices. So those are not acceptable rates. These are where we need to strive to at this point. And I won't go through this, but SAPIEN, understand the device, bovine pericardial, balloon expandable, understand the sheaths, the skirts and the heights and where you need to get a seal with these valves. Because PVL, this is where we need to be. And this is even higher than where we are now. Moderate PVL rates should be under 2%. And honestly, if you have moderate PVL, you should have anticipated, right? I know there are certain patient anatomies with LVOT calcium that I may end up with more significant PVL. But if you don't have LVOT calcium and you have nice annular sizing and a good CT, the moderate PVL rates should be 0 because it's much more predictable. And I think that's the key. When you have moderate, you should have anticipated it. And the reason it's important is early studies have shown that patients with moderate PVL do worse. And I think that's important. But with these devices have iterated with the SAPIEN 3 Ultra, the mild rates now at 30 days are less than 15%. Moderate 0.5%. And so, they continue to improve. And I think this is important. In terms of procedural technique, it's still a fluoroscopic guided procedure. You need to have a good coaxial plane. Now, if you're doing this with TE guidance, which a lot of people are not, then it's different. But if you're doing it angiographically, make sure you have a good plane. You can predict a lot of this from your pre-procedural planning with CT scans and everything else. In the majority of patients, I don't balloon. This is some early data. There's a lot of different studies out there. But the reality is the majority of patients, you don't balloon. But in asymmetric calcium, bicuspid valve, horizontal aortas, I do balloon. Because not only is it how the valve crosses, but how the valve expands. And I think that's important. I generally do an undersized balloon, usually a 20 or 22 for majority of patients. And then we saw an example from Sanjay's case earlier about a horizontal aorta and, deflect. Understand where the outer curve is, deflect. Don't let the valve scrape on the outer curve. And one of the procedure techniques I say is you can flex, but this is here. If you see, that's just pulling the wire. That's not flexing. So you got to have wire management. If you just keep flexing and pushing, you're going to scrape along the outer curve. You have to pull the wire as you go across. I think that's an important consideration. The stroke rates are low because I think the device have gotten better, but technique has gotten better, and we can cross atraumatically. This balloon allows you to cross even in commissures without the stent frame being the leading edge and avoiding BAV. In terms of positioning, we end up higher and higher, right? This is an old slide. This is not where we would generally position, but you want the valve to be about 2 millimeters below. So one of the techniques that people have sort of gone to right now is, and I'll stop it here as the contrast is in, is see this lucent line, the top of this lucent line at the annulus. If you do that, the valve will foreshorten up because the valve foreshortens from the bottom, and it varies in terms of how much to foreshorten, whereas a 29 millimeter valve will foreshorten by 8 millimeters, 8.5 millimeters. So those are all important considerations. Be aware of things like stored tension. The flex cath here is on the inner curve. And what happens, the reason this happens is you cross in a bicuspid valve in a commissure, you cross, and then you try to retract. As you retract the valve, you store tension in the system. And the reason that's relevant is that, this will store tension. And as you deploy, as you see here, this is an older version. This is not the SAPIEN 3. You can release that tension. So be careful where your flex cath is. Don't be on the inner curve. Things like that are always considerations. Conduction disturbances, initially the rates were 10%, but now they should be really 5%. And I think that's important. Annular sizing, avoid oversizing. That's what you get a rupture risk. With SAPIEN 3, we have a much better threshold. This is early experience. Even with 5 to 10% oversizing, the rates of moderate PVL are very low. Even in 0 to 5% oversizing, very low. So these are all important considerations. You don't need to oversize as much as we did in the past. And so that reduces the risk of annular rupture, but still getting a good seal. You can also oversize the valve. This is a patient where the perimeter is 690. And so negative 5% sizing. And with that, we got we can add volume, 2, 3, 4, 5 cc's, and you can overexpand, still get good central leaflet coarctation and minimal PVL. So you can treat larger annuli. This is an initial series suggesting that. With the Evolut valve, the results have been very similar. Hemodynamics have been great. Understand the device. The skirt goes up to here. The commissures go up much higher, but the waist there is generally narrower, 20 to 24 millimeters. This is going to be at the level of the coronaries. And so coronary access and everything else, that's going to be important. I won't go through this because we had a very nice example from the live case this morning from Dr. Grube and his team about how to deploy an Evolut valve. But the key thing is with the cusp overlap, it's not about being at 0. It's about being 2 to 3 below, especially looking at the membranous septum. If your membranous septum is 4 or 5 millimeters, your risk of a pacemaker is low. You don't need to be at 0. If you're at 0, you risk popping out. So we already had this live case. These are videos from Eberhard, but we saw that. But one of the key things I'll say is understand your position. This is a valve in a coaxial plane, but the valve has parallax. And that was the one of the questions asked by the panelists. When we take the parallax out of the valve, we see here we're much lower on this nod than we thought we were, right? So this is the annular plane. And so the lowest point here represents the lowest point of the core valve. Whereas when you take the parallax out, this plane represents the highest point of the core valve. And I think that's important to understand that there is parallax. It may correct as you deploy, but not always. We didn't need to balloon the upper valve, and I don't really have time to go into it, but when you have a significant LVOT calcium, undersize your post-ill balloon. Don't go to the nominal, go to the minimal diameter in the plane where you have the most calcium. There are anatomies such as this with significant LVOT calcium, and you need to understand that in these type of scenarios, the patient anatomy will dictate the result. If you try to aggressively dilate in this with a face sinus, you get a hematoma and things like that. I think those are all important considerations. So these all increase the risk of root rupture. So in these type of scenarios, you have to be willing to accept certain results. These videos are unfortunately not playing, but the valve didn't expand. We had PVL, and the reality is we ended up crossing and putting a plug because post-dilating isn't going to oppose that valve. And if you post-dilate, you're just going to risk injury. So either accept the AR or do some other technique such as paravalvular leak closure. And one of the things I really want to be careful with and emphasize caution is with the face sinuses. You see here that if the sinuses are big and bulging, you have room for the native leaflets to sit. But when the sinuses are face, you don't have room for the native leaflets to sit. And that's where you can get root injury. There's an example, really a face sinuses, no bulging, no difference between the STJ and the sinuses. And you have to understand during deployment here, watch what happens here. You see that we push into the root. And if you aggressively dilate here, here's the valve expanding, and you see here we're pushing into the root. If you quickly inflate and dilate, you're going to risk, rupturing the annulus. And so you have to go slow. And so we do gentle post-dilatation. You can always post-dilate, but you can't take away a root rupture. So you see here, this calcium is poking in, and you don't want to injure the root here. If you don't go slow, this is what you can do. You can injure the root, and you can get dissections and root hematomas as we got here. I'm going to skip through this because we talked about lifetime management a lot this morning. I'm going to go through coronary disease because, again, we talked about it a lot. But understand that without commissure alignment, this is what was discussed earlier. Ideally, if this red dot represents the left main, this is fine. You can get access. But if you don't have commissure alignment and the left main falls here, your access has to be from the side. And that's where the challenge is, especially when you have an effaced sinus. So in a core valve, I tend to consider PCI a little bit more aggressively because access may be a little bit more difficult. But for the most part, I defer PCI if it's single vessel disease, normal LV function, patients with increased bleeding risk, and where really the AS is the predominant driver of symptoms. But in a younger patient, you need to consider coronary intervention, because if you have prognostic coronary disease with triple vessel disease, you don't want to leave that alone. You're right. If you leave prox LED and fix the valve, they're going to die from their coronary disease. So you need to understand that. If you have depressed LV function with proximal vessel, I fix. If you have angina, I tend to fix. So there's a lot of unanswered questions, and we're going to get some studies such as complete TAVR, where they're going to help answer some of these, but we don't have all the answers. We talked about a lot of the issues of bicuspid. Calcified raphe is going to make the valve deploy in that direction. That can lead to root injury and angular rupture, or it can lead to non-circular deployment. As you see here, we got early experience and we didn't get a full deployment. And you got to understand that you have aortic root pathology as well. This was the largest analysis, and it showed that it's feasible. Low rates of conversion to open surgery or angular rupture, a little bit higher with bicuspid compared to tricuspid, but still relatively low rates. But this is a selected population, and that's important to keep in mind. Although there was no difference in all-cause mortality, there was slightly higher stroke risk, slightly higher pacemaker risk. But these were, again, very selected patients showing that it was feasible with low rates of PVL. And I think understanding in a bicuspid, the seal zone may be different. And in India, especially with bicuspid valves, the seal zone is relevant because you're going to see a lot more. And some of these patients, you need to land high, make sure the skirt covers at these leaflets, and you have to take that into account. And understanding these bicuspids, this calcium is going to play an important role. These calcified raphes are going to lead to asymmetric deployment. And in a core valve is supraannular, you may be okay, but if you deploy the core valve low at the level of the leaflets, you're still going to get asymmetry. So you have to understand that. And it's an example of a patient where we just didn't get expansion. Look how elliptical this valve is. Leaflet function is still not going to be normal. So we ended up ballooning this valve because we had gradients of 13, elliptical deployment, and we deployed the valve ballooned the valve post, and you see it's much more circular, and the gradients came from 13 down to 5. So understand, don't just leave that alone. Post dilate in those type of scenarios is what I would say, and dilate heavily up front. But radial strength matters, and this is inaccurate. You need to be able to dilate, expand the valve, and I think those are all important considerations. And this calcified raphe and the risk of contralateral injury, as you see here, as we go up with the balloon, what you'll see here again, we get pushed to one side, and that expands. So, in conclusion, transcatheter aortic valve has become a much lower risk and more predictable procedure. However, understanding the anatomy based on the procedural planning will help anticipate challenges. And understanding the device limitations is critical to optimizing results. So,
yeah, thank you, Susheel. Sir, youngsters nowadays are totally different and have various perspectives in interventional therapy, in cardiology coming up. And what are your advice? Just wanted to hear few words of advice to all the youngsters in the country and maybe in the world from you.
Well, certainly. Thank you, Srinivas, and Susheel, great lecture as always, and a lot of practical lessons. To my young colleagues, at this stage in my career, there's nothing that gives me greater pleasure than to be able to interact with the next generation of interventionalists. I think there's never been a better time to be an interventional cardiologist. When I look back over my career, I had very, very limited options and very limited opportunities, and we didn't even have a subspecialty. Now we have training, now we have education, now we have fellowships. Now we've divided interventional cardiology into the basics and coronary work, and then advanced coronary, endovascular, and structural. So the opportunities are endless. So to my younger colleagues, the first thing I would say is that you really need to take the time to understand this subspecialty. I would not rush through your training and assume that you could learn everything in a single year or a year or two. It takes case density, experience, and it takes the influence of many different mentors in order to achieve the kind of operator capabilities to allow you to be independent and to be successful in treating, especially patients with complex disease. So give yourself enough time during your training to become a qualified person. When you go beyond,
You need to give me a cue that we are ready to go, huh? Can somebody pump up all the back prices before we do anything?
Ujjwal,
All right,
mute them.
can we mute that line? Can we mute the live case line? Sorry.
great.
Sorry, Martin.
Okay. Second, I would say that if you're going to specialize, I would not dabble. I would do it with a great deal of effort and concentration. So if you're going to be a structural interventionalist, you need to learn imaging, which is echo and CT. If you're going to be an endovascular therapist, you have to understand vascular medicine. If you're going to do CHIP, you need to be able to understand how to do CTOs. And this takes, again, additional training and additional time. So I think going deep in one area of specialty, I think I would recommend. Even if you're not in an academic medical center, I think it's important for you to keep enriching your career by understanding the literature, understanding the clinical trial process, and applying the lessons of clinical research to clinical practice. So I think that, that's an essential element. So read the literature if you're not going to be writing the literature, and the extent to which you can participate in clinical research, I think it helps to enrich your career. Sharing the information, the experience you have, I think is critical with your colleagues. I believe that humility and giving back to the profession are extremely important. So I think being able to train others and to be able to work in a very collegial way and not be self-promotional and worry less about finances and quality of what you do, I think are important lessons that many of you should consider. They're going to contribute to the global reach and the global development of interventional cardiology. So I would encourage you to be global participants. Never to dream too big, and to have high goals, and to participate as part of the global community of interventional cardiologists. So for all of the young people, you have a very rich and exciting future. And I think you also have many senior colleagues who are very committed to helping you to be able to achieve some of your goals.
Thank you, sir. And we wish we had more time. One word which you mentioned, you may not be remembering when you came to do cases with us in the earlier TCTs. You said what drives you most. You said even to do good things in cardiology, you have to be in leading position. And otherwise, if you are there in some Timbuktu center, nobody will bother about you. Even to do good things, you have to be active and keep doing good work. And that's why you're a source of inspiration to all of us, sir. And before we close, I just wanted to ask, what is the most happiest moment in your life till now?
That's a difficult question. Well, I'll take family out of it, because family is always more important than your professional life at this point. I would say the most exciting thing that I experienced was the success of TAVR. The ability to be able to take a procedure that nobody thought could be done in desperately ill patients, and to provide a new therapy that was based upon a lot of experience over many decades and applying many lessons. So I think, and it's still magical for me to watch Susheel deploy a valve and be able to take a critically ill patient and watch them be restored to a meaningful future and be discharged in 1 or 2 days. So I think that TAVR, among all the procedures we've done, for me, has something of a magical appeal to it.
Susheel, any final question you want to ask, sir, before we leave?
No, I mean, I think, Marty, I think all of us struggle a little bit. We're always afraid of missing the next exciting thing, right? That fear of missing out. And you've remarkably transitioned and at different stages and sort of helped learn. And I think one of the things that you've taught me and just is, collaboration and the importance of collaboration, and allowing others to grow under you, right? The number of people that you've mentored and grown and taught and helped become leaders in the field is what I find truly remarkable. And how this afraid of people, things going past you, but you've never shown that. You've always let others take the lead on things. And I don't know if I'm asking you a question or not, but I think that is one of the things that I find truly remarkable. And for growth of a field and a specialty, we all learn from each other, and I think that's the one thing you've taught me more. It's more important than anything else, and to really collaborate, learn, and that not to be afraid of those around you.
I think that's what is benefiting us, Susheel. And thanks to a collaboration we had with all of you since last more than a decade, Indian community, all the cardiologists are benefiting. Thanks for all the support. One final question, sir. Any unfulfilled desire for you which you want to achieve? You all done. I think you are the most successful man.
I'm never all done. I get bored easily. You know, as Susheel says, I'd like to keep challenging myself and getting out of my sweet spot so I could learn new things. So I think that there are several more new developments that are going to be important in the future. And, you know, we've done a great job in structural heart disease. I'm particularly interested these days in heart failure. And I really do think that you know, that the transcatheter application of technologies to manage heart failure syndromes is going to be part of the future. So that's one area that I'm focusing on. But there are many things, Srinivas, I think that we all have to keep challenging ourselves. And I hope that we can continue to learn from each other. So
Thank you, sir.
Thank you for giving me this opportunity to be able to visit with you at TCT India, South Asia. It's a great meeting, and you are great friends and colleagues, and I cherish the honor to be part of your meeting.
Thank you, sir.
Thank you, Larry. Thanks, everyone.
Great.